Hello and welcome to the Global Nerve Foundation Fireside Chat. Our expert will discuss preserving and restoring sensation following breast reconstructive surgery. I am your host, Dr. Shafiq Siraj from West Virginia University in Morgantown. The Global Nerve Foundation is a nonprofit organization that focuses on improving the life of patients with nerve conditions. It was incorporated in 2021 and structured into 4 strategic pillars of awareness, education, research, and advocacy. Today's Fireside Chat is organized by the Awareness Committee and is intended to educate the public and help patients seeking proper care ask thoughtful questions and make well-informed decisions. Joining me today are Dr. Andrea Moriera, the Director of Innovation, Breast Reconstruction Services at the University of Pittsburgh, Dr. Ziv Peled, plastic surgeon and an expert in nerve reconstruction following breast surgery from San Francisco, California, Dr. Ann Peled, a breast cancer and plastic surgeon and the coordinator of the Breast Care Center of Excellence at Sutter Health California Pacific Medical Center, Dr. Rizal Johan, a professor and vice chair of the Department of Plastic Surgery at Cleveland Clinic, and Dr. David Whiteret, breast surgeon and founder of the National Breast Center and Foundation from Virginia Cancer Specialists. I thank my panelists for joining us today. I'm going to start by admitting that when I was in medical school, I really didn't know much about sensation and nerve-related issues following breast surgery. So I'm going to start by asking our experts a very high-level question. Is this something new that we just realized, or is it something that we just started paying attention to and we are able to address it? So I'm going to open up the discussion.
Great. I think you are completely correct. When the patient is diagnosed with breast cancer, certainly the focus in the consultations with the treating physicians and surgeons, it's surrounding the topic of cancer treatment, removal of the breast. And typically when they remove the breast, then the surgeon would remove the breast tissue along with the cancer and the nerves, and maybe even some of the particular blood supply. So with the current advances and evolution in surgical treatments, we acknowledge the knowledge of the anatomy that is very important to know where is the nerve, so that if possible, we would like to preserve the nerve and maybe reconstruct the nerve as well as the blood supply. So that is truly that we need to know about the anatomy.
Well, thank you so much. Actually, that's an excellent introduction to our next segment, which we will take a few minutes just to watch a brief informational video that describes breast anatomy with particular attention to nerve supply and how sensation can be affected or disturbed following surgery. Welcome back, everyone, and thank you, Dr. Whitemeyer, for the video. I'm going to start by asking, what type of surgeries affect sensation of the breast and in what way?
Well, as a breast surgeon who would be the first one to operate on a patient, and perhaps it's the only one operating in patients not undergoing reconstruction, all surgeries have the ability to affect sensations of the breast. I think I've put it into 2 categories, would be careful and well-trained surgeons, and ones who maybe, I won't say not properly trained, but maybe not focused on prevention and awareness of sensation-related issues, and then small and large surgeries. So as you go down the scale of each of those categories, from a lumpectomy to a mastectomy, and then when you start to involve potentially removal of lymph nodes and reconstruction, you just bring more anatomy into play, and therefore there's an issue potentially related to sensation. When surgeons go from being very focused and aware of the appropriate anatomy to less focused and less aware, you bring into play potential issues related to nerves and sensation.
Thank you. And how common is this, and how impactful can it be to have sensory loss following breast surgery?
I mean, I think when we think about sensory loss or impairment, we're kind of thinking about 2 pieces of it. So one of it is actually when you injure a nerve, you may lose sensation, but you may also have kind of bad pain, if you will, or other issues or kind of bad nerve issues at your site where you've had the nerve injury. And so I think that when we think about what we call chronic post-mastectomy pain syndrome, which is really a nerve injury in and of itself that causes chronic pain, that's actually been better studied and is something that we've seen impact sometimes in some studies as high as 60 or 70% of people. So I think we've kind of known that nerve injuries in breast surgery, particularly mastectomies, is actually a big issue for people and significantly impacts quality of life and other issues with healing and recovery. When we actually look at sensory loss itself, that's a somewhat more newly studied topic, but even so, a lot of studies will show that you're looking at as high as 3/4, 80% of people who are losing significant sensation in their breast and in their nipple if they have a nipple sparing mastectomy. So we know it's a huge problem. And we also know that it really impacts everything from sexual intimacy to how people feel about their bodies to how they can interact with the world and sort of have a functional impairment standpoint as well. So it really does impact a lot of people in a pretty significant way.
Well, that's interesting. It seems like 3 out of 4 patients who had breast surgery can be affected in a significant way. So does that mean that different breast areas can be affected differently, or is it all the same? And what does that mean to the patient?
That's a really good question. So certainly all depends on the anatomy. Different individual has a different nerve dominance. Where is it located more medially or laterally? Some people have more a larger caliber medial nerve or lateral nerve, but typically T4 is typically where the main nerve, and it could be affecting the whole breast, or it could be a portion of the breast. Really depend where is the nerve that is commonly cut and which portion of the breast affected. But typically it could be the nipple itself that becoming insensate, less sensation the whole breast itself. And sometimes patients can injure the breast skin because when they're cooking, they're not realizing they're too close to the stove. Some steam can come. And also when they hold the baby, sometimes they cannot feel the baby. It's interesting that when a patient we reconstruct the nerve and they hold the baby, they can feel the baby. That is something important that we don't realize how it can affect the outcome and the feeling of the breast in the psychosocial of the outcome in the breast reconstruction.
Thank you, Dr. Rizal. Just for clarification for our audience, you mentioned T4. What is exactly T4?
T4 is the thoracic level, and when you have ribs, we have 12 ribs, and then by fourth rib, that's where the T4 nerve is located. So mid portion of the chest, that's where the biggest nerve, usually the dominant nerve that comes around the lateral chest, or could be medially, and that goes into the nipple.
And did you say that different patients have different distribution of nerve supply from the same nerve?
Yeah, well, the different dominance, some people is more, we can see with during the surgery, we can see some of the nerve is a little bit larger caliber laterally, some people medially. And so it's a variation of the anatomy.
Thank you. And with that in mind, and when patients are planning for certain breast surgeries, how do we counsel patients about sensation following surgery?
That's a very good question because I think, what you discussed with your patients before surgery makes a big difference on outcomes and how they actually see the issue. So in general, when patients come to a plastic surgeon seeking reconstruction and nerve reconstruction, usually they're undergoing a mastectomy. So the whole breast is removed, whether it's nipple sparing, saving the nipple, or just saving the skin. That's when we are involved in trying to restore sensation. So when I talk to my patients, the first thing I like to tell them is that, for many, many years, we really did not pay attention to that because in our mind, we took it for granted, right? You're having a mastectomy. We know some of the sensation will be lost. And in the past, what we used to do is to say there's nothing that we can do about it. But we also know that even without reconnecting nerves, there might be some component of sensation that is actually remaining on the skin. And that can be anything from 10 to 30% is completely random. We don't know who is going to have good sensation and who is not. We have some ideas of what can affect that, but we can't really tell a patient for sure if they're going to be on the 10%, the 30%, or the 0% sensory recovery. And on that same level, we try to explain to them that sensation is important, because many times they don't realize that you're going to lose any sensation with the mastectomy. They think it's just the breast tissue that's being removed. When you explain to a patient that they might not feel their chest, that they're going to have a numb area in their bodies, and we can't project how numb that's going to be, I think it's a very important, it's a very powerful statement for them. So that's when they began to pay attention at sensation. So then we can discuss things that we can do to actually improve sensation. And one of the things is like what David said and Dr. Johan said, is to try to preserve as many nerves as possible during the mastectomy. So doing a mastectomy where you can follow the borders of the breast, you're going to be able to preserve a lot of these little nerves that you see on the lateral and on the medial aspect of the breast. And we know that if we do that, the patients will have better sensory recovery to the skin. And of course, we want to discuss about nerve reconstruction. That's exactly what Dr. Johan mentioned about the T4 nerve. So in general, I like to do a little drawing and explain to the patient that nerve doesn't go superficial on the skin. It goes through the breast tissue straight to the nipple. So when the breast is removed, that nerve is removed too.
Yeah.
So
Thank you, Dr. Moreira.
we need a little length of nerve to preserve that. And we discuss the outcomes and all the benefits that can have for the patient. And they have to make the decision if they want that addressed or not.
Thank you. And basically what I understand, there is some extent of sensory loss, and then we try to avoid it or reconstruct it, but we cannot judge how we're doing and what we're losing and what we're gaining if we don't know how to measure it. So that leads to the next question. How do we measure and evaluate sensation, whether before, during, or after surgery?
Another really great question, and I put the answer to that question in really one of two buckets. There are what I would call quantitative ways of measuring sensation. By that I mean things that we can measure, and you can do that in any number of ways. One, you can use these little monofilaments, these almost horsehair-like threads that are of different thicknesses, and measure how much pressure it takes for someone to feel light touch. You can do that same kind of thing in a linear way with a calibrated machine called a pressure specified sensory device. There's also ways to measure temperature and vibration sensation, as well as pinprick to like light discomfort. So those quantitative ways that have numbers that you can attach to them is one way of measuring sensation. The other is, and I think very important, the patient-reported outcomes, their perception of their sensation. And there are questionnaires that we have that can begin to assess how much sensation patients have at their nipple, at their general breast skin. And of course, it would be important to see from their perspective how important a role these areas of the body play, for example, in intimacy and in daily life. And in terms of timing of when you would evaluate these things, I think in a perfect world, you would have some kind of baseline, meaning before surgery measurements. And then you would repeat that at various time points up until perhaps even 2 to 3 years, at which point we think that patients are at that point going to have recovered as much sensation as they're ever going to recover. But it does take a long time.
Perfect, thank you. So what I'm hearing is what the patient describes before and after, and you can compare that depending on the different functions or the sensory function, if we can call it. And there are tools that you can use, and you can use it to also assess different aspects of sensations. It's not just sensation. There's heat, there's pressure, there is different perspectives. So that's very enlightful. Thank you. So with that in mind, how can we protect it, whether during surgery or by educating the patients or other ways? How do we limit the impact of sensory loss?
Good question, Shafiq. I think first, let's make sure that everyone understands that, at least in my practice, I don't view sensation as a luxury. I think there are certain elements to it, like you just alluded to, where it's actually an enhanced form of recovery. You know, whether someone gets to a point where they feel like they're normal and there's something they would consider to be satisfying relative to stimulation, or if it's just protecting against hot, cold, and other issues like you mentioned. I think that getting that mindset of the surgeon and the patient, so there can be a focused part of the conversation around sensation, and then really comes down to, I think, very simple, when nerves are very fragile. So don't try and break it. And if you break it, then be prepared to fix it. You know, the surgical plan. So it's a lot of things related to complications in surgery come down to having a very intimate awareness and understanding of anatomy, and then understanding that anatomy can be variable. So being prepared to deal with something that comes your way that maybe you weren't expecting. So we strategically place incisions in areas that perhaps won't have as much innervation, that will be disrupting by going in to operate. And then we're very careful of the tissue of the breast that's not the actual gland. So surprisingly, or maybe not surprisingly, there are blood vessels, there are nerves, there's healthy skin, healthy fat that we preserve, or we should be preserving during these surgeries. And that can be very protective for patients. And then ultimately, when we encounter, as you've heard from our experts, these number of dominant nerves with this expectation that if these are cut, and they're being cut not because the surgeon's neglecting things, that area of tissue has to be removed, either related to cancer treatment or prevention. There is the ability for nerve grafting, which we have experts in the panel that can describe, but it's either through autografting or allografting, reconnecting, allowing the body the ability to regenerate from the origin to the insertion of a nerve. So not overcomplicated. Try to protect these delicate structures. When you can't protect them all, because we can always protect some, then be prepared to handle them gently, and then have an expert in the room that can help restore sensation with some of the advanced techniques.
Thank you. So what I'm hearing is know where you're going, know how to handle your way around it, and try to save what you can. And if you cannot, get the expert to take care of it. So with that in mind, how do we take care of it after nerve loss, which could be in the middle of it, or it could be somebody who had surgery and then came back later seeking help because she's suffering?
Yeah, this is one of the key points of everything that we're going to be talking about. I think, as some of my colleagues have alluded to earlier, there are certainly many situations in which a nerve has to be sacrificed, or some portion of it needs to be sacrificed for oncologic or oncologic prevention reasons. In that case, the key is to save as much length of that nerve as is safe to do from an oncologic perspective. And then to reconstruct that nerve, you really have one of two options. Sometimes there are accessory intercostal nerves that are present that we have used to bridge the gap between the end of the nerve that we were able to save and the target that we ultimately need to reach because a portion of that nerve has had to be removed. In addition to that, we now have these great, what are called allografts. These are cadaveric nerve matrices, so a matrix from a human nerve, but the cells have been completely removed. So it's not a transplant. There's no immune reaction, no chance or virtually zero chance for rejection. And you can actually hook up or attach those nerves to the nerves that you were able to save. And then you have to find a target underneath the central portion of the breast, either just around the nipple-areolar complex or just within the nipple-areolar complex. And in so doing, whether you use the patient's own nerve or these allografts, the neurons or the nerve cells from the nerve that you were able to save will actually grow through those targets to reach, or through those grafts to reach their downstream targets and ultimately provide sensation to the areas of the breast that otherwise would be completely numb.
Perfect. Just for clarification for our audience, you mentioned accessory intercostal nerves. What is accessory and what is intercostal?
Yeah, intercostal means between the ribs. And so those are the nerves that provide sensation to the chest wall, superficial to the breast tissue. And the other part of the question was?
You said accessory. Does that
Oh,
mean they're not?
accessory. Those are, additional intercostal nerves because there are often more than one. Ideally, you could reconstruct multiple ones, but sometimes the location and caliber of those nerves doesn't allow you to do that very safely without using multiple nerve grafts, which can be difficult to obtain. And so in those cases, because many patients really have one dominant nerve that does a lot of the sensation, for example, just to the nipple or areolar complex, in my experience, you can actually use that smaller nerve that otherwise would just be cut and would be buried in the muscle to be used as a graft, using the patient's own tissue to bring sensation to where you want it to
It's
go.
almost like robbing Peter to pay Paul. You're taking a
Yeah.
nerve from a less important area to a more important area, I believe.
There's a little bit of that, but also knowing that oftentimes when you have to sacrifice those nerves, there are some, this usually a lateral, meaning to the armpit side of the breast. Some sensation will restore in those areas from the remainder of the chest wall. So oftentimes when you rob Peter to pay Paul, as you said, the area that you would rob from doesn't lose much sensation.
That's good to know. So let's say we have a patient, she lost sensation, she's ready for surgery. How do we counsel her about the reconstruction and recovery afterwards?
Okay, that's a very good question too. So what we want to explain to her, it's exactly what Ziv just described, how we are able to save some nerves and connect the nerve that got cut with a bridge of nerve to the Neurotization complex. So, and every time we do that, we have to explain to them that sensation doesn't come right away, right? And it's going to take a long time. Nerves grow 1 millimeter a day. So the first thing that they have to be counseled about is that this is going to take time and can take up to 2 years for that sensation to fully come back. So patience is key. The other thing that is really important to talk to the patients is that, you know, for us to evaluate if this nerve is working, we need to see them often, and we do need to perform those tests with the monofilaments to check if the sensation is improving. And another part that is really exciting about this is that Dr. Johan is going to talk about a recovery protocol that it's almost like a rehabilitation for the nerves. And we want to explain to our patients that we're going to ask her to do that after surgery. And we expect that recovery of the nerves to happen over time, that they might not be 100%, but it's better than not having any nerve recovery.
Thank you. So if I understand it correctly, it's not a one-time thing. You have the surgery and it's a done deal. There is some rehab that has to happen afterwards. So what are patients supposed to do, or what's the process?
Great. That is a very important question. Now, after we discuss the patients, the surgery, the process, now we would like to involve the patient in their participations, because their participations to have this process to be successful is they have to do the rehab. How do we do the rehab? The patient needs to look themselves in front of the mirror and then so that they can visualize where they're going to touch the breast. They're going to touch the 4 quadrants of the breast, and then as well as the nipple. First, they can use their fingertips trying to touch it, because then if by touching their fingertips, they're supposed to register in their cortical or their brain, where is that sensation supposed to be? Go to all different regions of the breast and the nipple area, and then do that at least 1 time a day, maybe in the morning and 1 time after the evening, after shower, in the bathroom, looking at themselves in the mirror. And after that, they can take a makeup brush, because it's giving a different stimulations of a different sensory stimulation, like you mentioned before. And after that, they can use a toothbrush, which is a little bit more coarse, a little bit brittle. It's giving them a different sensations. After that, they can take an ice cubes and trying to do sensory of temperature sensations. I don't like to give heat because I don't want to injure themselves about the heat, but they can use something warm. That should be fine too. Basically, do that at least couple times a day, and then they can see the progressions over several months. They will see the changes, and it is so grateful when we see the patients after months later. They can share their experience about how they are recovering themselves and gaining the sensation.
Thank you. Now, is there a period of protection early on? Can something goes wrong while in the early stages of healing?
So typically right after the surgery, patient will have numbness right away. So it is that, therefore it's quite important that they continue to do that right away. They might have some kind of cortical representations about where the sensation is supposed to be, but typically they will report or be numbness.
And I believe when you mentioned cortical representation, you're talking about the mapping
brain.
of the sensation in your brain. Thank
That's
you.
correct.
Thank you. So, okay, patients is ready. She's gonna do it. What do we tell her about success rate, and can something go wrong?
So this is a key point to be made here, and I think it relates to what I was speaking about earlier, which is how you measure your sensation to begin with. So if you look at the quantitative sensory testing that we do, which we call neurosensory testing, we test 9 areas on each breast, and happily, in the areas that we've tested, again, a minimum of 6, more likely 12 months, sometimes up to 2 years after surgery, about 80% of patients are testing in the good to excellent range of sensation on that quantitative measure. In addition to that, when you look at the patient-reported outcomes, that is, how do patients, no pun intended, feel about their sensation? When you look at various questions, for example, ones that say, how would you rate your overall breast sensation? Over 80%, actually 85%, say they have some or a lot of sensation in their overall breast area. And not surprisingly, for example, on another question on those outcomes measures, patients will still say at just slightly smaller percentage, for example, I think it's 68%, that their breasts still play a significant or somewhat important role in intimacy for them post-op. And this is in comparison to studies not long ago out of large cancer centers where barely a quarter of the patients were actually reporting measurable, forget good, but measurable sensation, both nipple areolar complexes. So we've seen large improvements in those numbers. In terms of what can go wrong, fortunately, we have not seen any major complications as a result of our ability to reconstruct and our work reconstructing these nerves or in work to preserve them. The one thing that I would say is that it does take a little bit longer in the operating room, and it does require, so we're talking 45 minutes to an hour once you have an experienced team. And that is the other point that I would make, is it really requires a team effort and a coordinated, constant interplay between the breast surgeon and the plastic/nerve surgeon who are doing this procedure together, which is something that's important to have in place if you're going to undergo or try to build this kind of operative team.
Thank you. Thank you. Now, our audience, I'm pretty sure, are aware that we have the best of the best in this group discussing this. Is this truly a common practice now, or is it still early and surgeons still have to learn how to do it? You're muted.
My dogs. It's kind of both in terms of it being new and also being something that's been around for actually quite some time. And so the piece that's been around for a while is actually restoring sensation after mastectomy. So since the 1990s, people have been using your own tissue, something called a flap reconstruction. Usually it's taken from the stomach, and they actually use that tissue to make a new breast. And so for decades, people have been using that tissue, bringing nerves up, bringing them up to the chest and using that to restore sensation in people who've already had mastectomies. And those results actually are very good. And that's been done for a long time. What's newer about this and kind of what we're talking about today is this idea of first trying to preserve nerves at the time of mastectomy. So it's kind of a different mindset to get both the breast surgeon and the plastic surgeon involved. So to keep the nerves that can be safely kept from an oncologic standpoint. Also, now we're able to offer this to people having other kinds of reconstruction, like implant reconstruction, where you don't have a nerve that's coming with the reconstruction, and you actually either need to use nerves from your own body in the chest that would be cut anyway, or use the nerve grafts that we've heard about. So that kind of is a newer piece that we now have technology to support this. So it's definitely becoming more common as we're seeing more surgeons getting trained in this technique, more teams, both breast surgeons and plastic surgeons, feeling comfortable and offering this to more people.
So let me follow up on that. Is there certain qualification for the surgeon to be able to do this? Certain training, certain background? Who is qualified for this?
So we all on this call and all of us feel really strongly about this team approach and how this really starts with the breast surgeon starting to look for nerves. And really any breast surgeon can be trained to do this. It does often require wearing a certain kind of magnifying glasses called loupes in the operating room that breast surgeons may not typically be doing, but it's certainly something we see people learning how to do, and they can be trained. If you're a breast surgeon who does mastectomies, you can be trained to do nerve preservation and look for nerves. In terms of the nerve reconstruction piece of it, as plastic surgeons, many of us have repaired nerves and blood vessels as part of our training, but for many of us, we're not doing that routinely anymore. And so I do think it's important when we think about nerve reconstruction that we're really thinking about microsurgeons or peripheral nerve surgeons, people who are used to dealing with teeny tiny blood vessels or nerves and putting them back together, because it is actually a very technical component of the procedure, and you want someone who does this day in and day out to make sure that you have the best outcome for the nerve reconstruction piece.
Thank you. We're reaching the end of our session together today. So my last question is, what do you think the future of breast reconstruction with particular attention to sensation is going to be?
Well, I'll start just because, I have a foundation, and our tenet is turning awareness into action. So just in my own practice, working with some of the experts on the panel, it's awareness that from a patient perspective, from a surgeon perspective, this is important and you can do something about it. And there are a number of ways that success can be developed, but certainly on the team side. So just getting caring physicians and obviously interested patients on board with that this even exists, I think is what will help propel this to be a more of a standard for these surgeries in the future.
Thank you.
I'll jump in there and say I think there's a couple of things that are really exciting in the future for us. I think to jump on what or piggyback on what David just said, I think also the more people that walk around having had successful results, which are much higher number than they used to be, certainly when I was an intern in surgery many, many years ago. I think having those people share their stories will be incredibly impactful, will also prompt other people to ask their surgeons and inquire about whether or not this is a possibility for them, and will encourage the surgeons that they might see in that area to investigate, learn about, and hopefully adopt these techniques. But I also think from a technical standpoint, as a peripheral nerve surgeon myself, there's a lot of exciting things on the horizon, specifically ways to image nerves so that hopefully we can continue to preserve more and more nerves in greater numbers, while still obviously maintaining oncologic safety, and then also identifying nerves even better than we are able to now to hopefully improve outcomes even further.
For me, actually, I do appreciate this GNF and the forum and really the spirit that trying to make the awareness, public awareness, patient awareness, educating and giving the message. I think more and more patients, once they know about this, as well as other surgeons who are willing to learn about this, I think that will becoming adapted and becoming the new norm for the future. Thank you.
I agree with Rizal, but I also, I have to say that what Zip said was really important, is that it's creating awareness, and the more people with success stories, the better. But I think there's a lot of technologies being developed, and there are new actually devices that will help us with the nerve regrowth over time. There are cameras who help us to image those nerves, so we can preserve them, like Ziv mentioned. So I think there's going to be a lot in the future with regenerative medicine, that will enhance the recovery of those nerves.
Thank you.
I guess to finish up, what I get really excited about is that we're learning so much more about what sensation really means, what it's like to kind of move past this and get people to a place where they don't think about having had breast cancer. They don't think about having had prophylactic mastectomies to reduce their risk of cancer. And so I think as all of us and more people keep doing these surgeries, we're going to have better data on, who has the best outcomes. What is that best outcome like? What does sensation really mean? There's still so much we don't really know or understand about this. And I think as we talk to more patients, see more people going through this successfully, it's really going to help us set expectations with patients and allow them to see that other side of mastectomies, which is a real gift to people getting past the surgery.
Thank you. And just to add my final kind of comments, it seems like as oncologic and reconstructive treatments for breast cancer continues to improve, it's allowing many more patients to live longer, but those patients also have to deal with the side effect of their surgery, particularly loss or diminished sensation. So this invites all of us to place a stronger focus on the long-term consequences of breast surgery and promote better quality of life, with particular extension to restoration and protection of sensation. Thank you, our panelists, for sharing your knowledge and experiences, and I thank our technical and administrative support who are working behind the scenes to make this session a reality. I also thank our audience for their attention and hope we were able to clarify some of the questions and concerns that they may have, and a very important yet not frequently discussed matter. Please be advised that this information is not intended to replace proper evaluation and treatment by a physician, and is only offered as an educational tool to make you better prepared for your visits. Millions of people worldwide live with nerve conditions that could be treated successfully to improve quality of life. The Global Nerve Foundation works with doctors, researchers, and patient advocacy groups across the world to raise awareness, aiming towards fulfilling its vision of advancing and promoting excellence in nerve care worldwide. Thank you so much, and goodbye.